Welcome back to the Only Healthcare Podcast. Michael Navin, joined by my co-host Randy Vogenberg, and we're excited today to have Jayson Slotnick join us. Jayson participated in one of our previous sessions, and so we're excited to have him back, really to talk about the year in review in 2025 and what we see happening in 2026. So Jayson, just like we'll just have you give us a little background and on yourself, and then we'll start rolling.
Well, good day, guys. Thank you very much for having me back. Really appreciate it. As you guys mentioned, I was here before. I had a great time. I work and live here in DC. I am a recovering lawyer, drug dealing swamp creature, as I like to say. And more importantly, though, I've had the pleasure of working with Randy for many, many years on trying to figure out how to provide appropriate access, really, to patients, beneficiaries in the commercial and Medicare sector as drugs continue to both rise in cost, but also have many more choices, many other kinds of diseases, and the drug expenditure of the plan, whether it's commercial or federal, continues to grow. It's still only about 12 to 14% of the spend, but it is the fastest growing portion, as Randy and I have talked about for many years. And so over the years, we've tried to figure out ways to make that drug affordable and accessible for patients, whether it's been reinsurance or value-based contracting. We've had a lot of very interesting discussions, and I look forward to many more. And so appreciate my time today. Your time.
Excellent. Thank you for being here.
Yeah, thank you, Jayson. So let's talk about 2025. Kind of a recap. Crazy year. A lot happened. Trump got reelected. We've from right out the gate had all kinds of executive orders happen. As you were mentioning, the cost of drugs, the affordability, as we go towards the end of the year now, has become the thing to talk about. A lot has also happened with CMS. So what sticks out in your mind is some of the big evolutions that have occurred in 2025 before we transition to 26?
2025, I'm going to split that into two separate categories. What was predictable and what was unpredictable. What was predictable about 2025 was the continuing implementation of the Inflation Reduction Act. Implementing not only from a government point of view, but really from a manufacturer point of view and a health plan point of view. It was the first year of the Part D redesign. It was the second year of generating the process for negotiated drugs. And with each of those processes became greater understanding of each of those aspects of the Inflation Reduction Act. Specifically around Part D as in David, with the Part D redesign, with now the out-of-pocket and the phase-in, we've had our first year under the belt of what the Part D redesign could be. So that was a predictable occurrence. We've seen how patients behave. We've seen growth in drug utilization. We've seen, unfortunately, a underutilization of the smoothing program. And we've seen some pharmaceutical behavior as a result of now the negotiation program, the other side of the big IRA implementation for 2025, with sort of deals and shifting in investments and licensing. All of that is starting to become better understood because of the changes in the Inflation Reduction Act in terms of the pill penalty and everything else. So we can get into that in a little bit. But from a big picture, that was sort of what was known, that would be a focus in 25. What was not so much a surprise, but sort of maybe a surprise of the focus of 2025 for the drug industry is the continued infatuation of most favored nation. Trump did signal that this was going to be a issue for him, not only because he did it and Trump won, but because he actually mentioned it on the campaign trail. So it wasn't such a surprise about that it was in the executive order, but it has been somewhat of a surprise in terms of the breadth and the depth and the consistent push on it and the way this is being unveiled and moved through the government has been more of a surprise in some way. It's been relentless. I think the word here of the day for most favored nation has been, it is relentless. Like as we sit here, there's even more rumor about more of it coming out, being more aggressive. So we shall see as time tells, but that's the long answer. The short answer is 25 was the year of IRA implementation, most favored nation from a drug industry, but I would be remiss if I didn't mention in the healthcare industry, you have to also add Medicaid reform and the Affordable Care Act tax credits expiring as sort of the four legs of the table, if you will, of 2025 year in review in healthcare. And then, of course, I would be really remiss if I didn't drop in the whole concept of artificial intelligence as sort of what is going on here, right? I mean, you can't have a podcast on healthcare and not talk about AI, right, Randy? So that's the 25 year review and sort of a big picture. And of course, right, none of that will go away in 26 to probably your next question.
Well, I had a question about what you just said. So there's a conflating ideas, right, between IRA and most favored nation, because they're two different, they come from two different sets of ideas, right? Two different negotiation tactics. How are those coming? How you said most favored nation seems to be creating a lot more momentum. So how do these conflate at this point? Like, what do you see happening with those?
So that's a good question, Michael, right? So by way of background, and the agency has made this clear, and we saw that with GLP-1s, right? Because we saw that the first generation of GLP-1s, right, Wegovy and Ozempic have a negotiated price, but yet you also saw those manufacturers have a most favored nation deal. So we have an example of how, though, to your point, those two processes are running in parallel, swim lanes, right? Parallel. So in one hand, they are very different. Another example is CMS is not allowed to use ex-US prices in developing an IRA negotiated price. So yet another example of how those are on separate swim lanes. And you can then say, thirdly, the IRA only impacts drugs at a certain timestamp post FDA approval, right? 9 years for small molecule, 13 years for large, whereas a MFN price, in theory, can impact a currently marketed drug, right? A drug that's been on the market or biological that's been on the market a much shorter time frame. So those are obvious differences that keep them in separate swim lanes. However, there are also, like you said, going to be points like in Ghostbusters where you don't want to cross the streams, but the streams are going to be crossed, which is if you start MFN on those drugs that are near term, right? What happens and how are you impacting the negotiation cycle? How are you impacting the overall benefit of the IRA or the processes of the IRA? What are you doing to the biosimilar marketplace? What are you doing to the generic marketplace? What are you doing to innovation and continuing the generations of next iterations of innovation? So there's a lot of yet to be thought through. I'm a little cynical that some of that is not actually being thought through, to be honest, because of some of the political and policy statements that have been made. But for now, IRA and MFN are very separate. That could change as soon as we see more proposals for an MFN on current drugs or not. We shall see.
So it's really up to the manufacturer to bring that to the table. Is that your point, where they have to come up with the most favored nation proposal, or are they hamstrung by the existing IRA?
So right now, everything is voluntary. Okay, so when it comes to most favored nation, what we know is something called the generous model. What we know is that is a voluntary model for the Medicaid program. What we know is that the government has said twice, hey, use 17 companies because they each received a letter in the summer. Hey, we want you to come to us with these parameters, and in exchange, you'll get relief on tariffs, which parenthetically, if the Supreme Court says the government doesn't have the authority to do, he's got nothing to give in exchange for the MFN price. That's a small little detail here, perhaps. Right. But we know that that was one voluntary, and the generous is another voluntary, which has now been lumped into that letter, right? So those letters were issued, voluntary come, and then we saw a couple of deals by 5 companies, and then the generous model was issued. When issued, the CMMI said that these 5 companies agreed to this generous model, which is essentially me as a manufacturer. I am volunteering to offer most favored nation price, the second lowest price of a group of 8 countries, to the Medicaid program in exchange for better coverage through a supplemental rebate agreement. Right? So everything so far is voluntary on the most favored nation. Most of us believe that the Globe and the Guard, which are models already under review by the government, one could impact Part B as in boy, one could impact D as in David. It can't be a nationwide mandatory model day one. The government doesn't have the authority to do that. It could be voluntary, it could be pockets perhaps of mandatoriness, but not nationwide mandatory day one. And so right now, yes, it's voluntary where the manufacturers can come and offer and try to get something in exchange on an MFN side. IRA is not voluntary. IRA is strictly your XYZ drug, XYZ date from FDA approval, and you fall in and you're ranked and you are in the vortex of the process.
And it's only Medicare, right? Like it's not federal employees insurance program or anything.
None of
just
this
Medicare.
none of what you are offering voluntarily impacts that per se, but it does bleed, right? There's no question about it that it will bleed, right? The maximum fair price will bleed into other programs on the commercial side. It impacts Medicaid because the MFP price is in best price. So, I mean, it does impact and it does bleed. So on one hand, yeah, you're only negotiating for Medicare. On the other hand, it's a small balloon and it's going somewhere. So yes, it impacts other places. So there's a lot of false choices around, I think, is the short answer.
So what I'm seeing, because my business is we have a prescription shopping marketplace called Peak, and we have sort of a you could shop for every generic, every brand, right? It'll give you the pricing, but we also have direct manufacturer relationships where we're connecting them with employers, and what we're doing is they're giving us their net price. There's no rebates, there's no anything, right? It's just net price directly to the employer who's paying the bill as a self-funded entity.
You're going to be competing with Cuban and Trump RX.
Yeah, that's what we compete with. Yeah, but it's growing, right? Because that's what people are seeing. Does that have any implication if those start to become more popular? I mean, you are seeing it with the GLP-1s, right?
Oh, no question.
But if is that going to start becoming the pricing for all? And do you think rebates will start to get pushed back and say, look, just give us the direct price?
I'm actually going to ask you, I'm going to turn around and ask it to you, right? So at what point does the insurance industry and the PBM, those vertically integrated, really start to take notice and care, right? Do they care that the no rebated genericized drug is going out the door and they don't need to manage it? No. Do they care that maybe they care some of the GLPs go out the door direct? The self-insured employer doesn't care, so their customer, the PBM, can't care, right? Will you see the $10,000 a month orphan drug, Michael? You will never have that in your business, right? You won't have that in Cuban. You won't have that at Trump RX, right? So that whole market is off. But we
do have biosimilars.
Correct.
And we're seeing
that's a different price point, right? That's a lower price point. So as Randy and I have talked about, right, are you starting to really bifurcate where we talk about as a reinsurance at some point? Can you see in 5 years where any drug below a certain price point is now direct to consumer outside the insurance business? And all because of the way drug is, because of the development of orphan drugs, because of the development of cell and gene therapies where those drugs are so expensive, where those drugs really start mirroring catastrophic surgical procedures and they become part of a catastrophic insurance plan. And all you're buying on the insurance is catastrophic drug coverage, and everything below a certain price becomes on you. And you actually do have a robust market of Trump RX, Cuban, and a whole bunch of other PBMs may spin it up. And maybe that's how the market evolves where you can make more affordable insurance products for patients? Perhaps. I don't know. I do think this is not here to stay. Said more positively, I do think you're going to see a growth of that for generics and biosimilars, like you said. I'm curious to see what happens. To your point about biosimilars, we are about to see the launch of 2 or 3 biosimilars for some very popular oncology drugs, and we'll see how that market shakes out in the next couple of years. Will those biosimilar manufacturers go direct to consumer? What do the physicians think about this? Because that's a lot of buy and bill money leaving their offices. What happens there? So yes, it's a trend, and we have it in a certain swim lane. Generics, some lower cost biosims, maybe some lower cost 505(b)(2) drugs. But
LOEs,
LOEs,
branded LOEs.
right. How it grows into where it grows, there are so many competing factors. You've got 340B lost revenue. You've got where initiatives that will reduce reimbursement rates for 340B at the hospitals, maybe move back to the community or move it to DTC. There are so many other forces that are going to come at that trend, such that it's really hard to know how broad and how deep that trend will go when it comes to accessing direct to consumer drugs.
Yep.
So let's dig in a little bit on this affordability issue, because that's what's really back in play 120% right now.
But Randy, let me ask you this. Sorry to interrupt.
Yeah.
Why is it that every other industry in our country, beef, milk, whatever, can raise price higher than inflation without a penalty? The only industry, the only commodity in this country that gets penalized for raising price above inflation is the drug industry. We're the only ones. You look at affordability, you look at what's going on politically, the price increase on eggs and milk, everything I just said, it's gone up. It's gone up. It's gone up. No penalty past CPI. Just the drug industry has a penalty past CPI.
Right.
And we're still a problem.
And it gets into all the other issues that have been going on for 30 years, which are going to take a while to untangle and maybe open up the markets for more competition that would act more like the grocery store items that you're talking about. But right now we're kind of stuck. But we're definitely in a transition period. And you got a lot of counterweight forces in play as well, as you're pointing out, just on the pricing elements. When we look at the commercial insured, because you got the premium costs are going through the roof every year for the last 3-4 years post-pandemic, and there's no sign of it abating. Now, they'll argue that it's drug pricing driven. On the other hand, you got the same problem on the medical benefit.
Hospital costs.
Hospital costs, right, exactly, where 340B comes in, which you also touched on. So there's a lot of activity happening. And so one of the other aspects of this has been what role does FDA play in this? So you got all the trade and commerce stuff happening around the pricing, the negotiations, but you also got FDA with Marty McCary also making a lot of changes in the past year that he's been around, not only in staffing but also potentially around how fast a drug's going to get reviewed and approved, and the new category around the additional condition for non-prescription use, ACNU. So where does FDA kind of come into this mix of issues as we're coming to the end of 25?
So let's presume, right, that the FDA's mission and role continues to be what it has been since 62, when the current FDA construct was created, which is determination of safety and efficacy. In other words, let's assume that they really don't get involved. It does not really get involved with drug pricing, which is starting to change. Well, let's park that to the side, and I'll answer the question to say the FDA's role has always been, right, safety and efficacy. So what can they do under that mission to help with drug pricing is to, right, create competition, right? Because in theory, at least I believe, right, that competition is the only force that does what we want out of the drug industry or any kind of healthcare service, which is to stimulate competition, stimulates innovation, and driving down prices. It's the only one that does that simultaneously. So to your point, Mandy, if the FDA can continue to evolve and update its processes, whether it's the approval of generics or to Michael's point about biosimilars, or to get those types of drugs to the market faster, right, and more efficiently to bring down prices, and to continue to stimulate innovators, to Michael's point about LOE and getting drugs out, right, new drugs, right, that will be very beneficial. Simultaneously, up front, to use AI or other kinds of platform technologies or models that we now are more familiar with to get drugs faster approved for the same reason, right? Competitive branded drugs approved faster. Also, that will work. So to me, the short answer, the FDA's role here is to continue to evolve to, under the safety and efficacy paradigm, to approve new drugs faster, and generics and biosimilars. Might be controversial for me to say that, because competition is the best for us, I think, as a society, because of what it does.
Sure.
Yep. Right. Yeah.
I mean, the other piece, I think, the headwind that you deal with is going back to your point, Jayson, about, the regulation and why there's these, CPI index, restrictions, is that you have so many games being played and so many cottage industries that popped up due to the rebates. And, you have aggregator companies, you have TPAs, you have wholesalers, you have pharmacies. And even when you think about the provider, right? So the provider being a pharmacist and a physician, right? They're the ones getting squeezed and they're supposed to be delivering the care, right? And so, but the insurance companies, the PBMs, are making record profits and they deliver nothing.
What you've just pointed out is, and we haven't gotten, it's been 20 minutes and we're getting to this now, right? The irony of all of this is what you just said. The entire system lives off of drug money, rebates. Mm-hmm. The entire system lives on +6 or whatever it is. That drug price is the core of everything. Randy mentioned and I mentioned 340B. And the more you hammer at drug pricing, you're going to start everybody, right? So it is so ironic that everybody who's complaining about the drug price is the ones who live off the drug price.
Exactly.
Right? They live off the rebates. They live on the add-on, yet everybody complains it's so expensive until we want to do something about it. And all of a sudden, no. We want to move from ASP to MFP and Part B. All the physicians in the hospitals are outraged. How are we going to make money on the drug? How is this? Right. You want to reduce the drug expenditures on 340B. The hospitals are outraged. We want to go to a rebate model to secure and protect covered entities and avoid duplicate discounts and avoid diversion. Oh, no, the hospitals are suing. No. Everybody loves to complain until we do something about it. And now, no, you can't do anything about it.
Right. Yeah. So here's the perfect setup that you just put in our lap. So what does this mean for 2026? So we shuffled the deck up. Everybody's upset. All kinds of lawsuits going on. Where are we going to be in 26? What's going to go down? What's your prediction?
So, I could give you a very, I'm going to start with a very technical prediction for 26, and then we can get into something a little bit more bigger, because I'd like to sort of start with what we know, right? What we know is going to happen in 26. What we know is going to happen is more on most favored nation, like we talked about, and more on IRA implementation, and more on commercial premiums, ACA, whatever it's going to be. Either it's going to be fixed or it's not. More specifically, by February 1, we're going to see the Part B drugs that are going to be announced for negotiation. That will be done by law. So the next tranche of drugs, which will include Part B, will be announced February 1. And so all of that, and who's on the list and who isn't on the list, we know that's coming. We know there'll be more about the insurance for the commercial market for 27. We're going to see all of those rates. We're going to see the rates for 27 under Medicare. And as we just said, those are going to be going up. And those are going to push the affordability issue continuously, because everybody cares about healthcare, right? Everybody needs healthcare. Yep. And so in the Q1, there's going to be another heightened or continuing heightening of affordability as it relates to healthcare, because the Medicare premiums are going to come out. the Medicare, the deductible and the out-of-pocket for 27, they're going to go up. And the commercial out-of-pocket and all of that is going to go up, predicted for 27. So that's the beginning of Q. That's going to start in Q.
When you say go up, you're saying out of the patient's pocket, not.
So in 26, the deductible is 615. That's going to go up for 27, and probably a dramatic amount, given the way the formula is calculated. The 2100 out of pocket under Part D as in David for 26 is going to go up for 27. Probably a considerable amount of money, given the way the Congress required CMS to calculate that money. And we're going to get to a point in the near term where we're back where we started when we fixed Part D, where it's going to be even under smoothing. If you've got a 2,700 out of pocket smoothed over 12 months and it's $200 or more dollars, that's not going to be affordable on a fixed income for millions of Part D seniors. We are also headed towards 2029, where you've got the 6% cap on Medicare premiums going away that the IRA put in there. So that premium number that you even see now, the monthly, it could explode. Part D is being subsidized, the freestanding, by the government. And Biden put it in. Trump didn't like it at first, and now is trying to figure out how to wean it off without the monthly $35, $40 premium going into three digits, right? $100, $150. So that's going to be in Q1. You're going to hear a lot about that. That's just Medicare. And then you have the commercial, as Randy and I have discussed, similar pressures, right? There's going to be similar discussion about premiums, right? And benefit design and benefits and maybe accumulators and maximizers in Q1. So that we know is coming in 2026. We know that. What we also know is that there'll be more noise on Most Favored Nation. We know that. In the second quarter of 26, we're going to see rules coming out of the federal government related to hospital inpatient payments, hospital outpatient payments that will go at just that, right? Payments to inpatient, and then maybe 340B, reducing that. And then towards in that time frame, to pick up on Randy's question about FDA, PDUFA, the Prescription Drug User Fee Act, PDUFA needs to be reauthorized by the end of Congress in 27. So that already we are starting to worry about what's going to be in there and all of that. So you might start seeing some noise there for your question on 27. That's all that we know. And then what we don't know is what we don't know, right? We don't know where the government's going to be on prior auth and AI and other hospital issues and trying to control Part B spending, fee-for-service spending. There's a wiser model out there. There's this access model. And the government is going to continue to push the envelope, ironically, of CMMI, which they've stated they hated because it came from the Affordable Care Act, but they're going to use it to their advantage anyway. How they're going to continue to push on all of these voluntary models and where the pushback is going to be. So those are everything we know. Like I said, what we know, what we can anticipate. And then, like I said, we don't know what could possibly happen from a healthcare point of view. We don't know what's going to happen with the vertically integrated entities. Will the FTC do something about it? Will the Congress do something about it? Will there be PBM reform at some point? I'm skeptical on that. So that is something else we could speculate on, but I don't think will actually happen. But to finish my last sentence, and I'll turn it over to you. What I do know is that 26 will be as nutty as 25. It'll be as exhausting from a news cycle as 25. And so maybe it's job security for us, Randy. I don't know.
Yeah. It's the full Consultant Employment Act.
Yeah. Look, what I tell all my clients is the three things I say the most, I've been saying since January 21, is stay current, stay calm, and stay focused.
Yep.
Yeah. So I guess the last piece of speculation as we go into 26, the whole movement that we're seeing coming out of the far left now with Mondami in New York as mayor. We have a Miami mayor now, not quite the same, but similar. Seattle, same thing. What's the repercussions potentially on healthcare for this real shift and looking towards more socialism? Some say communism, but it's certainly different than the capitalism and the competition that we've been talking about.
Yeah, I think it's one thing to have local governments transition to that philosophy as an elected leader. I think it'll be curious to see what happens, to your point about 26, in November of 26, when we have an election, how that transitions into the federal electorate. In other words, to your point about Mondami, a lot of progressives, very progressives in New York, have now announced to challenge traditional Democrats in the city. And will that occur more so nationwide? Likely. How many of them will win? We shall see. And then we can wake up at the end of middle of November and see what impact the new Congress will have on healthcare from a progressive point of view, to moving towards maybe a single pay, whatever. That's the only place that they can go. I don't see a single payer really having much more steam than it currently has, even with the electorate. I know it's talked a lot about, but still, I don't know that it's a policy that the overwhelming majority of Americans would support.
Mm-hmm.
I think the noise will be there, but I don't see it now. Now, everything I just said 15 minutes ago about the rising cost, collapse of Part D, we may get there in the next decade or not. But it's so hard to predict because we don't know what impact AI is going to have on healthcare costs, or the GLP-1s, or all of that will have on healthcare costs going up and then maybe going, who knows? But I don't see a dramatic shift federally, progressively on healthcare in the near term.
Last question that I have is from the commercial side of the market, because they're looking now, they seem to be more engaged around change.
Who's the they in that sentence, Randy?
The employer marketplace, whether they're self-insured or fully insured. So the non-government programs, the way to kind of look at it. Everything takes time. It's going to be slow, similar to what we see with the government. But on the other hand, it seems to me that we may have an opportunity from the commercial side of the insurance market that may see change a little bit faster. And would that be an indicator of what may happen or the government programs may pick up on to see what works in the commercial side that they can apply on the government side?
My guess is that the commercial side will just be more aggressive with current federal programs. And what I mean by that is they will get more aggressive with the larger physician groups and maybe having them assume more risk, right? This concept of affordable accountable care organizations, which have been around since the Affordable Care Act, is there, right? But I could see the commercial plans, having watched physician groups consolidate and grow and go into hospitals, right, for the 340B issue, finally waking up and saying two things. Number one, to Michael's point a few minutes ago, I'm going to directly purchase drugs. I'm tired of the middleman. I don't trust my PBM on that. I want to see what I can do on a direct to pharmacy, and they will change some of that. Now, the PBMs tell you, right, some of it is already, all of it is transparent back, but I see on the drug side, the self-insured getting much more involved in both spectrums of the drug, the cheap ones, and maybe the more expensive ones with reinsurance policies or add-on per member. Again, they tried and failed. There wasn't the volume, maybe. And then on the other side, Randy, to your point, seeing the growth of the IDN in certain communities and the physician groups, I could see the employers saying to the docs, hey, I'm not doing buy and bill with you anymore on the drug side, and I'm not doing all these negotiated rates off of Medicare. Let's transition into something that looks a little bit more two-sided risk with patient outcomes, because this is not sustainable what we have going on here. And you guys are large enough to assume the risk. And we want to do that with you. And we'll even do more than a 1-year contract, 3-5, whatever it may be. I could see that happening from the employer point of view, or they just don't do it, or they just don't offer the health. You know what I mean? We could start transitioning away from other kind of tax credits, HSAs, depending on the Republican solution to the Affordable Care Act tax credits, where we start transitioning away, which was an idea opposing the Affordable Care Act 100 years ago, where the Republicans were saying, hey, why don't we just give the employee, the individual tax credits and let them go shopping and get their own insurance. That could be the counter to the progressives with single payer. We could see that again. But again, who knows? That's a, philosophical policy pie in the sky swamp creature debate. I think from a more practical purview, Randy, I think the answer is the employers will use what is already available federally more broadly and more aggressively before they come up with anything new.
Okay.
What I've heard from some of our PBM colleagues is the watershed year is for the 27 benefit year, which is they've seen all these new and upcoming, the employers are seeing these new and upcoming PBMs compete with the bigger ones, having more innovation, using technology, to your point, Jayson, and then just keeping, 100% transparency and pass-through in the rebate. And then they see the impact that has on the cost savings. And they're starting to seriously take these companies and put them in consideration to switch their business. Yeah. So, 27 could be a shift in the traditional, big three PBM, right? Obviously, they're not going anywhere, but you said it earlier about them paying attention. They're going to start paying attention this year. And what does that really mean? Are they going to change their models to keep satisfy their groups, or are they going to just continue to do what they do and hopefully no one changes?
And it might be where we don't see the change in 27, given the patent cliffs that are going to occur in that year. Like I mentioned before, some significant some significant costly bees and boy drugs are going to have LOE, a lot of biosimilar entrants, and that may save the PBM model in 27. Right, when you have all those biosimilars coming in and reducing all those costs and the formulary development, that might save them for a year or two. And we've seen that in the past, right? There are all these seminal years where you have a lot of patent cliffs, and that has saved the model. So that may happen too. Too. We don't know. We'll see.
Yep. No, it's a good point.
We'll see. But the employers, I think, from what I understand, you guys tell me, we are in this interesting inflection point where, to your point, Michael, where the employers want to see net. I want the lowest cost. I'm not interested in rebates because I know you keep it, right? They want that piece. Yet the Medicare program lives off of rebates. That's the oxygen, right? Because that's what helps drive premiums and everything else. So you've got this manufacturer pricing conundrum. Do I come out high and rebate, or do I come out low? Depends on my payer mix, all these other. So that will continue to be interesting to watch, to your point, about what is the employer doing versus what is the federal government doing.
Yeah, I mean, going low right now is not a good strategy because they won't even reimburse your product. Because if you're not putting a rebate associated with it, they won't even take it on formulary, right? Now, if you have an alternative channel like ours and others, we'll take every drug, right? So now the employer can create their own formulary with zero copay, zero prior authorization, zero restrictions. Right, and it's just this drug's available at $300. We'll pay 100% of the cost. So there's all kinds of things happening.
Yeah, exactly.
Yeah. There's going to be a lot more to talk about, and that's what we like to have: is more controversy, the better for our podcast. So we covered a lot of material and concepts today. We're going to continue to do that in 2026. We'll probably have Jayson on more regularly, along with some other folks, talking about some of these issues as we track the changes or no changes that happen as we go quarter by quarter in the next fiscal year. So thanks for joining us today, Jayson. We appreciate it. We love your insights. Michael and I enjoy having you and having these kinds of conversations, and hopefully the audience appreciates it, gains some insight and information around how change can happen in the marketplace and the role that consumers can play increasingly as we see these markets develop in the next couple of years. So thanks to everybody for joining us on this Only Healthcare podcast today. You can always check us out on the onlyhealthcarepodcast.com website. And we look forward to seeing you again on future episodes.
Thank you guys very much. Appreciate it.
Thank you for tuning in to the Only Healthcare podcast. We hope you found today's episode insightful and informative. Remember, our mission is to provide actionable and inspirational insights on how we can improve healthcare cost, care, and accessibility for all. If you enjoyed this episode, please subscribe, rate, and share with your friends and family. For more resources and updates, visit us at onlyhealthcarepodcast.com. We'd love to hear from you. Let us know what topics you'd like us to discuss in future episodes. Until next time, stay informed, and together, let's navigate the journey to better healthcare.